Hey everyone, welcome to live chat with Nurse Linda. Today's topic is nerves. Let me tell you a little bit about Linda. She's a leader and provider of rehabilitation nursing for over 30 years and a friend of the Christopher Dana Reeve Foundation for close to 2 decades. And now I'm going to go turn it over to Linda. Hey, Linda.
Hi, thank you, Julie, and welcome everyone. It's lovely to be here with you again today, and we're going to talk about nerves. Ironically, I had been writing about the phrenic and the vagus nerve because they're so important in the blog, but just as coincidence, I would love to say it was all planned out, but just as coincidence, we did the webinar about the Stimo. If you got to see that, this big announcement that was made last week, maybe about 10 days ago. It's all happening so fast that it's kind of hard to remember, but it's been on the news. It's this device, implantable device called Stimo, S-T-I-M-O. You can look it up if you would like. It's a device that's being produced by the Onward company, and it is a stimulator that's put into the lower spine to improve walking function and to work really mostly in the lower body. But they've got a lot of things going on. So I highly recommend you look up the Onward website to get more information about that if you're interested. Now, I do want to put this caveat out there, and that is that not everyone is interested in electrical stimulation. Not everyone gets excited about when there's a new announcement. You know, we've heard announcements about new things, and, you know, then you don't hear anything about it for a while. But it never hurts to gather information, to know what's going on out there. If you're interested or if you're not, that's perfectly fine. Some people want to wait until things are more tangible, more real, before they get excited about these things. But if you have an inkling, or if you're just curious about it, be sure and look at their Onward webpage, where you can get information about all kinds of things that they have going on, including some studies about stimulation for the upper extremity if you have tetraplegia, or if you have some upper extremity issues. There's the lower extremity stimulation. Anyway, they have a lot of things that are going on. So you can sign on to their website to get email notifications about what they're doing and how they're doing it. And so it's good if you want to keep yourself educated on these things, on their priorities, their research priorities. I do want you to know that there are other people that are also working on electrical implants. One is the Big Idea, which is one of the projects that the Christopher and Dana Reeve Paralysis Foundation is supporting. They've also provided some support to Stimo. There's other projects. The Cleveland FES Center is one, and there are others. And I'm not going to go through the whole list because surely I will leave somebody off. But there's a lot of people who are working on electrical stimulation. Now, electrical stimulation is not a cure for spinal cord injury, but it's a treatment to help regain function. Just so you know, there's those subtle little differences. The Stimo project, they have demonstrated with people walking with a walker, so you have to have hand grasp to be able to walk with the walker. At this point in time, all of this will change and evolve as things progress, but it's the project is being introduced. It's a little different in that they implant what they call a stimulator array. And what it is that they have electrodes on a length of material, maybe about that long and about that wide. I'm probably being way too overgenerous with it, but the electrodes are placed on that, and then they insert that in the epidural canal, and then they program that array with the different electrode points to the different points on the spinal cord that need to be stimulated and how much each individual needs to be stimulated. So it all gets adjusted, and it can also be adjusted afterwards. There's a little wiring that comes around to a power pack that's implanted under the skin. So if you think of like a cardiac pacemaker, or if you think of one of the Medtronic devices for like baclofen pumps or pain pumps, it's kind of all the same idea. So you can program that battery pack to work in different ways. So anyway, it's very exciting. We're very happy to see that progress being put out there. So I was talking this month about different nerves and stimulation of different nerves that we don't always think about, because we think about stimulating nerves for muscle function, for using your hands, for using your legs, even for balance, bowel and bladder, sexual function in males. There's all kinds of surface, we call surface, which means electrodes that are put on the skin. Those are surface electrodes. And there's implantable devices. So there's a variety of things that are going on in the electrical stimulation department. But there's also, and some people will be interested in these two particular nerves, one being the phrenic nerve, which is the nerve that really works the diaphragm. Now, breathing uses many nerves, uses many different muscle sets, but the main powerhouse to breathing is the phrenic nerve working to pull the diaphragm down. The phrenic nerve is referred to as one nerve, but it's actually two. It comes out of both sides of the spinal cord, but it works in unison. Both of these two nerves work in unison. So that's why they're always just referred to as one nerve. But it's actually two. So you could have function on one side, not so much function on the other side, and still be breathing, maybe just need a little assistance, or if it's not working, you're not able to breathe. And so you can get a stimulator implanted onto the phrenic nerve to stimulate that nerve to work. It's used a lot in pediatric for different kinds of problems. So, we talk about all kinds of paralysis. There's some children that are born with paralysis of that phrenic nerve, and they put this little pacer in there and off they go, just, breathing with use of their nerve. There's also diaphragmatic stimulators that are very popular right now. That is, I want to say that's out of the Cleveland area. It might be the Cleveland FES Center as well. Dr. Anthony DeMarco, and Dr. Anders both do those phrenic nerve stimulators. The pediatric blog for this month has a lot more information about those, because for adults and in pediatrics, that pacemaker is out on the market now. So people who have injury of some sort where they can't breathe for whatever reason, it could be a head injury, it could be a spinal cord injury, it could be something altogether different, can get that. Instead of going on the mechanical ventilator, you can get this phrenic nerve stimulator, which is all implantable. And so you have less chance of infection and complications. One of the greatest things I think about it that people don't often think about is you're no longer connected to that hose and connected to the mechanical ventilator. So it's easier to move around because you're not worrying about this becoming unattached, and so that the person can't breathe. And it's a lot more easy to move around, to do your ADLs, to do your exercises, because you're not constantly battling with that machine. So a lot of trauma surgeons are putting them in. Of course, pulmonary surgeons are putting them in. But a lot of people who are in traumatic accidents currently that get placed in trauma centers will have the diaphragmatic pacemaker put in, and they never go on the ventilator. If you've been on the ventilator for years and you think, well, that sounds really great, you can talk to people, to your healthcare professional about switching to a diaphragmatic pacemaker. So you could imagine not having that hose and that machine, and the noise that it makes and all that. I would imagine you're so used to the noise now, it would be weird not to have the noise. So anyway, they're just all these kind of things that are going along with electrical stimulator. Another one is the vagus nerve that controls just about every organ function within your body. So if that has an injury to it, that can also be stimulated. And they're doing a lot of things with the vagus nerve for paralysis, but also for other kinds of illnesses like chronic epilepsy. If you're having chronic seizures, that's another alternative. Stimulation of the vagus nerve can help some people with that. It won't help other people. So, it's all very individual how things will work out for any particular individual. But these are therapies that are available now. This Stimo and a lot of the implantable functional electrical stimulations that are going on are futuristic kinds of things. So Stimo has had a proof of concept study, which means that they have taken this from the laboratory, they've had implanted this in people, and it's working. So they show that this works. In 3 or 4 years, they plan to start their study here in the United States. Now, the company that is doing this has been around for several years. They're a very aggressive company, and sometimes people can think of that as negative. But in this case, it's a very positive word, in which case that they're aggressively pursuing this, they're making it happen, and they're doing it the right way. So you might want to look up Onward if you're interested and see more information about what's going on with that. So with all of that, let's get to the questions now. You might have some questions, and if you would like to put those in the question and answer box as we go, that's perfectly fine too. You can view the Stimo interview. It's an hour-long webinar that's put on that will hopefully answer any questions that you have about it. There is a question in here about somebody attended 3 months therapy in Miami in 1987. It was very early for FES treatments. Yes, it was. They included FES and biofeedback along with intense physical therapy. And they started with Drs. Nash and Green. And when they started after an hour, it took an hour to get all the electrodes hooked up, and worked up to a quarter of a mile a day before they left. She could not, she was using the FES bike, and she could not pedal one turn when she got there, but was pedaling. So I have been involved with the FES bikes and a lot of the FES research. Christopher Reeve took advantage of the early FES studies, and I was lucky enough to be able to help coordinate that the Christopher Reeve Recovery Project. Meeting him was probably meeting one of the finest individuals on the face of the earth. He was really a crusader, and I think about him every day. He was just such a wonderful person, so kind. And my husband also had some healthcare problems, and he would call him up and just talk to him. And he was always calling different people, especially young kids that had spinal cord injury, to encourage and motivate them. And he was working on the international stage, and yet he had time for everyone. Just a fabulous individual. But he did get to a point through all of his therapies, which included FES biking, aquatic therapy, partial weight-supported walking. Through all of his therapies, he also did some biofeedback, didn't appreciate it too much, didn't really like it so much. But that's okay, because what works for one doesn't work for another. And, we're all a little different, but he did all these therapies, and he was able to walk in the pool and use all of his muscles against gravity with the buoyancy of the water. It didn't translate quite yet onto land, but he made huge improvements in his function, and he made gigantic strides in his sensation. So it appears, not proven, it appears that when you get more motor movement, that your sensory just kind of coincides and improves with that, sometimes even more so. So if you have sensory function, it's so helpful, because where you've got a pain, if you need a seating adjustment so you can avoid pressure injury. And there's just a lot of things. As Christopher Reeve said, we were like, well, what was the greatest thing about your improvement? And we thought, we'd say, oh, his function, his mobility. And he was like, well, clearly it's the sensation, because I can feel the hugs of my family. And oh, yeah. So, we get so tied into the science of it that we sometimes forget to look at the human part of it. So life is good today here in February of 2022. But one of the first questions that's put into that's been asked was about the prices on the stationary bicycles. Now, we know that functional electrical stimulation has been demonstrated by several different labs, by multiple studies. There's a lot of positives that go on, and it's still very difficult for people to obtain functional electrical equipment through their payer. It's very, very pricey. That's why it's so difficult to obtain. So are the prices coming down on the bicycles? Well, yes, they are. I heard of a company that is selling them for $12,000. It's a scale down model, no bells and whistles. As you go cheaper, you're not getting less of a device, but you're getting less of the alarms and alerts. And so you have to kind of pay more attention yourself, which, that's a trade-off that's easily made. And the prices of bikes will continue to go down. So keep an eye on that, because that is happening. The prices are already coming down. There's several options, and as there's more and more competition, there's going to be more and more options available. There's a question, we're going to deviate a little bit because there's a question that somebody just wrote in. They are 21 years into their spinal cord injury. Their level was, he says, C4, C5. So he has a suprapubic catheter. Those come in and out. Those are really popular again right now because of autonomic dysreflexia and worry about reflux into the kidneys. They were in when I first started nursing, then they went out of fashion, and now they're back in because the payoff of safety in your kidneys is so important. So his bladder is very, very small. Urodynamic studies. The suprapubic catheter keeps your bladder urine free. It's constantly draining. The bladder's a muscle. Without that natural stretch to it, it slowly starts to clamp down there. So he says his quality of life has become unbearable because he's getting AD every 5 to 10 minutes. Please assist. Well, if you're having it that frequently, please call your healthcare professional, because that, is affecting your cardiac system. So you need to have that looked into every once in a while. Every 5 to 10 minutes, you need to talk to your healthcare professional. There are medications that can be given to you to control those AD episodes so that they're not happening. There might be some treatments to the bladder that might be done. If the bladder's the trigger, they might want Botox, for example. I don't know in this case, they might want to do some Botox to reduce that trigger. They might try to do some different exercises to enlarge the bladder so that you're not having that problem. But an AD episode every 5 to 10 minutes is way too much. So you need to get on the phone and, I need some attention here about this, because that is a serious situation. So be sure and get on that even today. That would be a good idea. Here's somebody had written in that they had the MotoMed bike and it works well, but it's very pricey. They're all very pricey. But they're great. If you can get them, it's really a good thing. Now, some people get the FES bike, they put the electrodes on, they think, oh, this is not going to be a problem. I could just sit here and do this all day. You really need to work with somebody who knows what they're doing, because you want to be able to get the waveforms and the rotations and all these, different specifications for you. And remember, you probably haven't exercised your legs at this level of function for quite some time. Now, you recall before your spinal cord injury, anytime you exercise, if you're doing your upper arms, and you start exercising, what happens? You get a little stiff and sore because we haven't exercised them for a while. So you really need to be cautious once you get an FES bike that you're not overdoing it. You might not feel it. You're stimulating your legs are moving. I don't feel a thing. If you have some sensation issues and you think, oh, okay, this is no problem at all. but your body does feel it, even if it's not registering up in your brain. So remember, the first day you're on that bike, you're not training for the Olympics. So pace yourself, go slow, don't trigger your AD episodes, don't overtire your body, don't over fatigue your muscles. Work with somebody who can advance you as your body can tolerate it. So your therapist will have knowledge and information about how to do that. So just don't think I can hop on this bike and I can just bike all day, because, exercise does not work that way. Just because you have a spinal cord injury, or if you have a stroke and you're stimulating one side but not the other side of your body, think about all these kind of things. You want to stay safe with yourself. Now, all of this, FES is a treatment. Anybody can get an FES treatment if your payer pays for it. If your payer does not pay for it, you can try FES to see if it works for you. And that is by using, even in Medicaid or Medicare policies or private pay policies, there's usually 2 weeks of mobility training, 2 weeks per year in your contract. Almost all policies have that in there. Well, FES is not learning to walk, but it's a precursor to walking. So it is mobility training. Your 2 weeks doesn't have to be Monday through Friday for 2 weeks. It could be a day, a week for 10 weeks. It could be 2 days a week for 5 weeks. So work with your healthcare professional. Say, I want to try this FES. See if you can get in with your 2 weeks of mobility training. Then you have some evidence to take to your insurance company to say, look, I stimulated well. I'm able to tolerate this treatment. It was beneficial within this time frame. You can use that to your advantage to build your case. Now, when you submit to your insurance, which your healthcare professional will have to submit to your insurance to order an FES bike. Okay. The first thing that will come back is you will get a letter, or the owner of the policy will get a letter. So if it's your spouse, if it's for your child and you're the parent that owns the policy, or if it's you that owns the policy, you will get a letter and they'll say denied because it's not covered in their policies. So then you have to appeal for it to get a special permission. And you only have so long to do that. So once you get that letter of denial, you have to run it right over to your healthcare professional so they can write the appeal, because there's a time limit on doing that. So you might get a second letter back that says, no, you can still appeal again. You might get a third letter, no, appeal again. Keep appealing until they give you a final result. So a lot of times people are, oh, I got this letter, I don't get it, I can't have it. No, keep appealing. That's what the appeal process is for. So keep working on it. There's a gentleman here in St. Louis, I've spoken about him before. He was on the news because it took him 6 years of appeals, and he finally got it. And he went on the news to encourage people to keep appealing to your insurance company. Now, of course, that was on the news and it was great. And people like me were just like glomming onto it. It didn't reach a large audience within the news community, if you think about the entire population, but it was good lesson learned. There are appeal processes to insurance, so just keep going with it. The next question is about somebody who wants information about clinical trials. The best place to get information about clinical trials is clinicaltrials.gov. It's a website, clinicaltrials, one word, .gov. And that's where anything that has any kind of federal funding, any study that's going through the FDA will be on that site. It covers everything. So you have to search for spinal cord injury, and all the studies that have been approved will come up for spinal cord injury. You can use this the site in a number of ways. You can narrow it down to spinal cord injury, functional electrical stimulation. There will be all the studies. So you can use this in a number of ways. Number one, you can see what studies are out there, and that's great. Some of those studies will not be near your home. So you can look at, maybe it's they're trying a certain drug, or maybe they're trying a certain treatment. Maybe they're doing a questionnaire and you can participate because it's by mail. So look at those studies. If it's a drug and you want to try that off-label drug, go to your healthcare professional and talk to them about it to see if it's right for you. Sometimes as individuals, we don't really know all the ins and outs of healthcare. So talk to your healthcare professional. Well, you won't be in the study, but maybe we could try this treatment off label. It could be a drug, it could be a therapy, it could be, an FES protocol, it could be, a variety of things. So that's also information. When the studies close, they will have a report of the findings. So if you're interested in something in particular, you can take those findings. Look, they did this study. This is not, treatment that's out there, but this study, look at, they were this much percentage successful, and I'd like to try that. So there's an abundance of information. If you are interested in something in particular, like a particular drug, if you're interested in a stem cell research project, there are companies that are working on stem cell treatments. You can look up stem cell research, and these company names will come up to you on the computer, much like looking at Onward's website. Look at these other companies' websites and follow the progress that's going along. So, all kinds of great information. There's a woman that wrote in who has a son who's in constant pain, bedbound, chronically depressed. So I would recommend to you as mother to get your son to the healthcare professional. If he's in chronic pain, there's treatments. Now, neuropathic pain, that's nerve pain, is hard to treat. And so you're going to have to look at multiple different therapies, from a lot of movement, exercise, maybe some pain medication, maybe some Botox injections. And we have a question about side effects of Botox injections. And so, Botox injections are put in based on the knowledge that the person delivering the drug has. So they know that if they're doing Botox into legs, they know that this is about the average amount to start with in Botox in legs, in the leg muscles. So they start out with that. For some people, it might be a little too much. For some people, it might not be enough. So the next time they'll kind of up it or lower it, depending on what comments that you provide to your healthcare professional about that. So, people come in all shapes and sizes. So if somebody's going to go get Botox and they're a 6'4" man that's got huge muscles, they're going to require a little bit more Botox than an older, say, woman, because women's frames are less. We have less body mass than men. So they're, a smaller lady will need a lot less Botox. So, the person who delivers that knows these different factors. And so a lot of getting that perfect dose is a little bit of trial and error. Now, you could go in there, have your dose, and it could be, that's my dose, and off you go. But sometimes it takes a little bit of trial and effort. Sometimes they won't up your dose way too much because they don't want to put too much Botox and you make you all floppy and not able to do anything with your spasticity. So it's kind of depends on what your goals are, how you want to do that. And this person is talking about that they're having some scissoring in their legs, and it's making catheterization and different things a little bit trickier. So does it weaken the legs? Does it weaken sensation? Does the Botox weaken your legs? No, because the whole muscle is not being treated. It's just little bits of the muscle are put in. So Botox is botulinum poison, and it's poison. Now that's, people are like, oh, I'm not having it then. But it's medical treatment. So they put in just enough that it weakens some of the muscle fibers, but not all of the muscle fibers. And you have to have Botox treatments over and over again. They have to be continually done to keep up with the reduction in spasticity, because the muscle grows back. The whole muscle is not destroyed. There's just little tiny, tiny fibers of it that are weakened. So they do grow back, and then the spasms come back. And so that's why you have to keep having routine injections of the Botox. So that's what Botox does. It weakens the muscle fibers just a little bit, just so that you don't have that severe spasming going on in your body. So that's how it works. And that's why you have to keep up with it. Let's see, here's another person who's has a son who's very depressed, is in a nursing home waiting for transfer to another facility. And so this is an issue that we often see, is that sometimes people get placed into facilities, which is not necessarily a bad thing, but sometimes facilities don't have a lot of young people. They're not really set up for dealing with young individuals. But in just about every state, I don't know of any that's not, you have they have programs for you to return to your home or to a home. There are programs that can help you where you can find caregivers that can come into the home. Now, some insurances pay for caregivers, some insurances do not pay for caregivers, depending on your level of injury, depending on your policy. There's just a whole lot of things. For people who have spinal cord injury, stroke, multiple sclerosis, any kind of paralysis, any form of paralysis, we all know that families are relied on a lot to give care to those people. So it is the kind of thing where, you know, you have to decide how this is going to be. So for some individuals, insurance is not going to pay for a caregiver to come in. And then you have to figure out, well, can a family member do that? Are they willing to do that? Do they want to do that? Sometimes families really want to do that, but then they find it overpowering, that it just is so encompassing in their lives, or they have to go to work so that you can pay for the insurance policy that you do have, and then there's nobody to be there at home with you. So there's different kinds of living arrangements. There are group homes, there are long-term facilities. If you talk to the peer mentors, and there's a peer mentor program at the Christopher and Dana Reeve Foundation, they can hook you up with maybe somebody who's been through this process and can give you a lot of the ins and outs, a lot more than we can do on the webinar. But maybe it's people who have succeeded, maybe it's people who have not succeeded, but they're still working on it. So people can talk together with their peers, find out what's going on, find experts in your state. There's information specialists that can help you connect with different state programs. If you're a young person like these two individuals are, there's a vocational rehab program in every state. You need to get on a waiting list to get into that voc rehab program. Sometimes it's a number of years before you can get in, because there's a lot of people with a lot of different issues that are getting into voc rehab, and they will help you with return to work, as long as the goal is return to work. But they will help find a job that you can do. If you need to go to someplace, what are the resources? How are you going to get in and out of your house? How are you going to get to your job? Transportation. There's all kinds of programs with that. So think about that kind of thing, and then work with a peer mentor and work with people on a one-to-one basis. Different areas have specialty services for people with different ability levels. So working with different organizations like that can help you also in figuring out how you can do something different. So those are all possibilities. Now, it doesn't say if they're waiting to go to another facility because maybe you're waiting for a pressure injury to heal, or a surgical site to heal, or there, you know, maybe you have to build up your tolerance before you can participate in the 3 hours of therapy that's required on a daily basis. So sometimes you need to be in a transitional place where you're building your strength and getting better and getting stronger until you can get to another spot. there are people in the peer support network that have been through those kinds of things. And so they can kind of, it's really nice to talk to somebody who's lived it, especially when somebody has been successful with getting through that. So I would highly encourage you to be sure and talk to those kind of people in your area. And you can start right through the Christopher and Dana Reeve Paralysis Foundation. So here's an interesting question about osteoporosis and what can be done to help that when you're paralyzed. Well, the first thing you want to do is to not get that. I imagine this person's asking because they've already been diagnosed with that, but there are things that you can do to prevent it and also to help treat it. So we'll start out with preventing it. First of all is to eat a well-balanced diet, because you need to have all the nutrients in your body to be able to keep your bones healthy. So sometimes people think, oh, calcium, I know I need to drink a lot of calcium, but sometimes that can cause kidney stones too when you're not moving around a lot. So talk to your healthcare professional about the kind of diet you need. Talk to your healthcare professional about if you need any dietary supplements. And as I say, like calcium, people, well, I can just go buy that off the shelf and I'll just start taking it, and they'll start taking, and then they're taking too much and they run into problems. It also might affect some of the other medications that you're taking. So before you take any kind of medication, whether it's prescribed, whether it's over the counter, whether it's recreational, be sure and check with your healthcare professional or your pharmacist. They have a computer program with all your medications in it. They add in a different supplement and they're able to tell you, no, you shouldn't be taking that because of this, or you can take a small amount or whatever, but just don't start taking anything just because you saw it on TV. It can be very dangerous, especially when you have multiple healthcare issues. So that is one thing, is to eat a healthy, well-balanced diet. Then you don't need calcium if you're eating a healthy and well-balanced diet. Another thing to do is to get what they call a standing frame. And most insurances pay for this. It has to be requested, but most insurances pay for this. And you kind of sit in a chair, you transfer into a chair, and there's either a hand pump or a pneumatic pump that will put you into a standing position. Now there's a brace that goes across your knees. There's a brace that goes across your hips. If you have a higher level injury, there's a brace that will go across your chest. You might even need a head strap to hold up your head. Those will create new areas where pressure injury can occur. So you have to be very careful and look at those areas as you do when you're looking at your sitting and lying areas. And so get a standing frame. Again, it's not the kind of thing where you can just get in it and stand up all of a sudden. People have orthostatic hypotension where they change position and they lose their consciousness. So you have to build up to working into these things. Just as you had to build up your sitting tolerance to sit in a wheelchair for hours at a time, doing your pressure releases, you have to build up your tolerance to these straps. You get pressure injuries across your knees, you've got a pressure injury, and that's, we know that that's some trouble. So you have to be hyper vigilant about these things. Again, you have to work with somebody. You might use that 2 weeks of mobility training. Yes, standing is mobility training. And so that can get you into the standing frame process. Now, there are some wheelchairs that allow standing as well. So if you can get a standing wheelchair, now that is a hot ticket item. Again, that's something that insurance is not going to eagerly pay for. So, but if you can get one, you can be standing in that standing frame, but you're putting the weight through the long bones of your body. Now, there's some scientific research that says that standing helps with your bone minerals, and there's some that says it really doesn't. So talk to your healthcare professional about that. Moving your legs, moving your body, moving any part of your body helps maintain your bone density, because as you're moving that muscle, or somebody is moving that muscle for you, that muscle is pulling on the tendon and that's pulling on the bones, and that increases your bone density. Who knew? But that's the way it works. So sometimes people think, oh, well, I'm not using my legs, I don't need to move my legs. You know what? Doing that range of motion, doing those those exercises, that's, my legs are heavy. That's hard work. Yes, it is. But the payoff is so huge, because moving your legs moves your muscles in your legs, moves the muscles in your abdomen, stirs up your abdomen, reduces bladder infection, stirs up your abdomen, moves the stool along in your bowel. It helps move your legs so you're getting a little more blood flow to those areas that can be prone to pressure injury. So there's just all kinds of things. It even helps your breathing. So there's all kinds of things that moving your body craves moving. You don't know it if you have sensation problems, but your body moves. I wish, we should make a list. You have to breathe to survive. You have to eat to survive. You have to move your body to survive. You need to have, your body craves that movement. And even though you don't feel your leg moving, you might see it moving, you might think about your leg moving while that's helping, that helps create that nerve regeneration. But also when people move their body, they just feel good. And so you might not notice it through one series of exercises. It might take quite a while, but over time, if you're continually moving your body or having someone move it for you, you will notice, hey, I'm feeling better. I just am in a better mood. It affects your mental health. So moving your body is just a great idea. So then also with osteoporosis, then if you have, you need to have your bone density checked one time a year. Now you go, it's fine. Oh, I can skip a year. Well, it creeps up on you and you never know when it's coming till it's there. It's not like this many years after your injury. It could be a brain injury, it could be a stroke, it could be a spinal cord injury, it could be multiple, it could be any disease or injury in the nervous system will affect your bone density. And we don't know when it's coming. It's like a thief in the night. So you go, it's fine. I'm not going to go for a couple of years. And then you got bone density problems. Your bones become very brittle. You have to be very careful about moving your body. So if you have osteopenia, or if you are diagnosed with osteoporosis, osteopenia is like beginning bone density trouble. Osteoporosis means you have a lot of fragility in your bones. They look more like spider webs, almost more than a solid bone. And so there's medications that you can take for that to improve your bone density. So hopefully, you'll take the precautions and then you won't need the medications. But if you do get on the medications, you can improve your bone density and then you can start with your standing. You can't stand if your bones don't have enough density to hold up your body weight because they'll just break. Is it true that within days after suffering a spinal cord injury, osteoporosis sets in very soon after injury? I heard you can also urinate bone sediment, which is actually a sign of osteoporosis. True or false? Okay, good questions. So do your bones start losing density right after? Yes, there is a phenomenon where that happens. It happens to some people, but not to everyone. But as you start your rehab and get moving those bones, it will start to correct itself. So that's the first thing. So you need, that's why we put people in rehab right away. So that can help with that. Can people actually urinate out the calcium in their bones? Yes, I've seen that. But not all sediment in the urine is calcium from the bones. So sometimes people have a lot of sediment in their urine for a variety of reasons, and it really has nothing to do with bone density. Sometimes people have a lot of sediment in their bones because that is a sign that their bone density, that they're leaching a lot of minerals from their bones. Just because you have sediment in your urine does not mean that you're losing bone density. Also, if you have sediment in your urine, you can have that without having, I think I just said that, without having bone density, but you can have sediment in your urine. But anyway, sediment gets in people's urine for a variety of reasons. So if you have sediment in your urine, you've checked it out with your physician and, oh no, it's nothing to do with your bone density, that's okay. There are some people who you can actually see that sediment, which turns out that it is osteoporosis, but there's no rhyme or reason to it. So it's not like if it's there, yes, that's true. And if it's there, no, it's not true. You have to have the bone density test to see what's going on with those bones. And you really need to have it yearly. And if you come out with a negative test and you're having no problem with with your bone density, put that in the win column, keep doing what you're doing, and go back the next year and have your bone density test again. That's one of those things that you really can't let up on. There's somebody who's interested in a sure hand lift. This is one of these lifts that move you from place to place, and they want to know how much shoulder strength is required for a person to be transferred, and they're C5 quadriplegic. Well, sure hand has a variety of different options. So for some, you don't need any shoulder strength at all. If you're trying to do it on your own, you might need more shoulder strength if you're going to be using your lift on your own. So they have, it's like a Hoyer lift seating sling that you sit on, and they have different ones. They have low ones that are below the shoulders, one that are above the shoulders, one that have it that comes up above the head. So you're in there, and then there's some straps that go around your legs, and they have like a metal thing, a metal bar where you put your arms up so that you can pull yourself if you have the strength to do that. But if you don't, you can still use it. There's some where you can just lay your arms up there. Sometimes you just cross your arms in front of you so that the sling will do it. There's a little button device that you push. It can be connected to the ceiling. Some of them will just be like a Hoyer for you're moving from one position to another. Some have the ceiling lift so that you can get in the sling, fly into the bathroom, sit on the toilet, do your bowel program, fly over to the shower, get in the shower, get out of the sling, put yourself in the chair so you can move all about your house in the sling. Again, if you can get it through insurance, that's great. It's really way down on the list, but sometimes, you can find people who are compassionate and will help you get those kind of things to improve your independence. Even if you have somebody else moving you, if you're high level quad and that person is having difficulty now moving you because perhaps they've gotten older or whatever. So sometimes people will get these lifts, not because for their it's for their personal use, but not because they're using it themselves independently, but because their caregiver needs to use the lift for them. So there's various different ways that you can hit that problem from different perspectives. So somebody wants to know how to move forward, and their fiance needs to get a job that pays enough to cover the financial costs of life after spinal cord injury. So again, I would look at the Voc Rehab. If anybody who's looking for a job, get on the list for Voc Rehab. I wish that, and some facilities do, they put your name on the Voc Rehab waiting list the minute you enter the rehab hospital, which is really great because, you want to waste no time waiting on that list. You want to get going. Some states have more Voc Rehab resources and people that are working in Voc Rehab to help you than other states. So, it's just kind of the luck of the draw where you live there. But if you can get involved in that, that's really good because they do so much of the groundwork and they've done it before, so they know how to get things done. So there's some great stories from Voc Rehab, how they have gone to different companies and talked about employees and what their needs were, like, can you work from home? Working from home has become a big thing since COVID has been out. Another thing is, can you work alternative hours? So if you need to go in a little later and work a little later, or can you go earlier and go home earlier? Can you have a rest break? Now, it seems to me, and this is only observation, it seems to me that the larger company you work with, the easier it is to get resources within that company. So if you need to catheterize during the day, you need to go to a place that can do it. Most bathrooms, even if they're handicap accessible, are not accessible to pull your wheelchair into a stall and try to do the catheterization. They're just not that big enough. So bigger companies have more resources to accommodate. They might even make a private bathroom for you to, where you really have room to move around. Some companies will provide a place where you can take your break and you can go lay down, get out of your chair. Some companies, the larger companies have more resources to do that. Smaller companies might not have that kind of resource. You need to be able to get in and out of the building, that kind of thing, what to do in case of an emergency. And the Voc Rehab will go and they will help talk to the managers about your particular needs and, how to handle those emergency situations. What if there's a fire and you need to get out and you're on the second floor and you can't use the elevator? They take care of all that. They think of everything. So if you can get into something like that, now if you're getting your first job and you find somebody who's able to work with you and say they're in a smaller company. Now, I'm not saying smaller companies won't do the same kind of resources that larger companies will do. I'm just saying they probably don't have the resources to do all of that. But if you work for a smaller company, sometimes you can build up your work history. So you can show you can arrive on time, you can do your day's work, you can maybe work part-time someplace. Any kind of thing that you can do to show that you are a reliable worker and that you're capable of doing work is a good thing, because sometimes people have misconceptions. It is unfortunate, but we all know it still happens, where they see somebody in a wheelchair and they think, oh, they probably can't do this job. So, you need to kind of demonstrate that you can do that. That's an important thing as well. If you had dreams of a certain kind of job, maybe it required a lot of physical labor and you can't do that sort of thing now. So, think what kind of things you can do within the realm of that job. So frequently I know some truck drivers who've become injured. They're unable to drive their truck. Some people have adapted their truck, but they're unable to drive their truck. So they go into the dispatch area. So just think about, trying to think out of the box. It doesn't mean you have to do something totally different. It doesn't mean you have to become a computer specialist. That's what they always say. Well, you can work on the computer. Well, not everybody enjoys that kind of work. So, just think about outside the box and, see what kind of things that they're out there. Sometimes you can get a volunteer job to demonstrate your ability to work. If you have a religious affiliation, or you can go to a church where things are more accessible and kind of house of worship. They're usually a little bit more accessible. Just think about what you can kind of do, what you would like to do. You might need to volunteer for a while, and then maybe that volunteer job turns into a regular job. It's the same for everyone, but there's a lot of jobs open right now, a lot of jobs for working at home, so you wouldn't even have to leave, which would be great. A lot of jobs come with job training. So there's all kinds of opportunities that are going on right now. There's some organizations in your community. So if you identify with a disease process, there's different societies. There's the multiple muscular dystrophy association. They're all around. Multiple sclerosis, they're all around. So if you identify with a disease process, that's an opportunity. They might have some jobs or know some kind of job assistance. There are different foundations. There's a place in my hometown called Paraquad, and they help find people. It's a foundation, but they help people with all kinds of things, but not every community has that kind of resource. So be sure and check in your own community to make sure. The YMCA is another place. Goodwill is another place that will help. Now have programs for people who are alcohol and in alcohol and drug recovery, but they also help people with physical disabilities as well, and that's not too widely known. You can see in the chat box, there's a link there to click about employment and work programs. Okay, what makes legs contract, and is there anything that can be done about it once it starts? So I think you're talking about spasticity, which is what it's more commonly known, but there's it's now called tone because that's more correct, but most everybody calls it spasticity, and that's a correct contraction of those nerve fibers. So within each muscle, there's its own separate stretch reflex, and muscles want to contract. That's why people who don't use their muscles, will kind of have all kinds of contractions, like in their arm or legs, always towards the heart. Muscles always, because there's a balance between pushing muscles and pulling muscles, and so your muscles will always contract inside your body. But that comes from spasticity, and it comes from tone. If it's very mild, you can range it out, move all those joints and stretch that out. It will fatigue the muscle, and that relaxes the tone. As the tone gets stronger and stronger, you may need some medication that can be taken orally, or you might get some Botox injections, but you still need to stretch out those muscles to keep all those muscles from contracting and keep those muscles supple. If the spasticity gets really bad and it's impairing your movement, you can get the Botox injections, or you can get the a baclofen pump put in that will help relax your lower spinal cord. So those are all kinds of helpful kinds of things. So you just want to try to keep it from advancing, but you can do everything and it still advances, because sometimes the muscles are just taking over with that need to contract. So that's kind of the hierarchy of treatment for that. But if you catch it early, you can kind of slow it down a little bit sometimes, not always. But anyway, those are some options that you have for that. So some people have it, some people don't. People who have higher level spinal cord injury, people who have strokes or head injuries often get spasticity and their muscles contract. People with those lower level spinal cord injuries don't, because they become atonal. They don't have any tone in their muscles, and they're more flaccid in their function. Now, think about tone, and you might not want to completely eliminate your tone, because if you have a little bit of tone in your legs, sometimes that's very helpful for transfers, because that allows you to support your body. So there's some good things about tone, and there's some not so favorable things about tone. So those are kind of some of those things. It's lots of considerations. Carrie D wrote in, and she's a vocational rehab counselor by trade, and she says that link up there is good for exploring companies who've transitioned to a remote workplace. Great place to start searching and to get more information. So that's the thing. If you have, the more you know, the more able you are to navigate some of these things. And remember, it doesn't just happen overnight. It's just like you can say, hey, I'm going to go out and get a job. That doesn't happen for most anybody. They don't just say, I'm going to get a job at this company and this is the job I want and that's what I'll do. It just doesn't work that way. It's trial and effort. It's finding the right fit. It's trying to, the right fit for you personally as well as physically. There's a lot of things that go into it. You might need to start someplace and, move up in the company. That's just the way it works. So these are all kinds of things to think about. And, it's the same thing with paralysis. You start out one day and you can't maybe use your arm too much, and then you start doing some exercises. Maybe you build up some strength using some muscles that just need to be strengthened. You get a little bit something, maybe you use a piece of adaptive equipment, and that helps. There was a question about here, does anyone know of crutches that are able to stand on their own, or if you need to use your hands? There are some crutches that have armrests on them. so you can use your forearms if you don't have a lot of hand functions. Some people with lower level injuries will use something called a reciprocal gait orthotic. And that is a gait that when you move one leg, the other leg will respond appropriately. They're very heavy and they're cumbersome. They're hard to get used to, but those also work with crutches or a walker. And some people like those. There's all kinds of orthotics that will help support your legs if you have some hip flexion, but you don't have lower level action in your legs. There also, if you have a lower level injury, one of those flaccid injuries, you can get something implanted in your body. We started with the stimulators because the peripheral nerves are the ones that come out of the spinal cord. So at the base of the spinal cord, there are some implants that you can put on there that help leg function, bowel and bladder function, and sexual function in men. Unfortunately, not in women, but in men. So, there's a lot of things. Like I say, the more you delve into this, the more information you have, the more you're going to find out about things. So these are all important questions. They're great questions. It's been a great day. We've covered a whole list of information. So please remember that I am available to you through the Christopher and Dana Reeve Paralysis website. You can contact Nurse Linda. You can contact me directly. I have blogs every week and the webinars the last of the month. For questions like this. There will be a webinar every other month. The next one will be April 13th with Dr. David Gator, who's a specialist at the Miami Project. We were talking about Miami, and he's a specialist in Florida who works on energy and metabolism after spinal cord injury. So that's going to be the second Wednesday every other month starting April 13th. But that one will be more scientifically presented. But again, many people in our community have more scientific knowledge than I will ever have. So hopefully that will be helpful to some people. But there's also the webinar at the last Wednesday of every month. And then I just want to, before we sign off, we're at the end of our time, but I just want to make sure, I think we have answered all the questions. So with that, I bid you a happy day and I'll see you next month.